Dr. Edelstein has been helping families for many decades and has supported thousands of families in their pursuit of parenthood through fertility treatment. Dr. Edelstein trained at the Jones Institute. He received his training under the American father of infertility, Dr. Howard Jones. He will share about advances in treatment and things that may be possible in the future that are not possible today. So without any further delay, I'm so pleased to introduce him and to share his perspective about the future of family building.
Hello, my name is Dr. Michael Edelstein, and I'm a fertility doctor with Shady Grove Fertility in Richmond, Virginia. And I would like to talk about what I believe will be the future of in vitro fertilization. Where will this field be in the next decade? What will be different? What will be better? Now, when I finished my fellowship in 1990, my mentor, Howard Jones, the father of IVF in America, made some predictions about IVF for the next decade. Dr. Howard predicted that we were going to find a way to pick the better embryo to transfer. He predicted that we were going to lower the chance of multiple pregnancies. He predicted that IVF, while a very safe procedure, would become much safer. And he also predicted that IVF would be available to many more patients. Well, in the next decade, most of what Dr. Howard predicted came true. We can pick a better embryo to transfer. We do that by growing embryos to day 5, by doing time-lapse photography, and most importantly, by doing genetic testing. We've markedly lowered the chance of multiple pregnancies by doing single embryo transfers. But we've eliminated or almost eliminated one of the major complications of IVF, ovarian hyperstimulation syndrome, by triggering patients with GnRH agonists. And in terms of making IVF more available, well, there are special financing programs, money-back guarantees, more insurance coverage, but we've got a long way to go in that regard. Now, what are my predictions for IVF in the next decade? Well, the first thing we have to remember is that right now, for a good responder patient going to a reputable IVF program, IVF is a very successful process. If we transfer a high-grade single embryo, the chance of a patient getting a baby is basically a coin flip, 50-50. And if we do multiple transfers, the chances are much higher. And most good prognosis patients ultimately achieve a baby. And when we think about this, we have to remember that in nature, there's only a 20% chance of getting pregnant each month. So we're more than doubling the success of nature. But I do believe that IVF will become more successful in the next decade. First, we're going to do more genetic testing of embryos. Today, more than half of patients elect to undergo pre-implantation genetic testing. But I do believe that by the end of the decade, every embryo will be tested. We know this because IVF genetic testing is becoming more accurate. At one point, we did FISH testing. We've moved to next generation testing. It will become a more accurate process. Now, we know today that we do have issues with mosaic embryos. We have some embryos that are tested as abnormal that are clearly not. There are false positives. Because we know there are times where embryos that have been identified as chromosomally abnormal result in the birth of healthy children. But over the next decade, it will become more successful and the process will become much cheaper. And this is true with all technology. Today, to sequence the entire genome of a patient is hundreds of dollars. The first patient that had their genome sequenced, it cost $1 billion. Now, the last decade, we've mostly focused on the embryo. But we still know that when we transfer a chromosomally normal embryo, a minority of the time were still unsuccessful. While the last decade was the decade of the embryo, the next decade will be the decade of better understanding of the endometrium. For many of us, most of our transfers are programmed. We give exogenous medications, estradiol, progesterone, at standard doses for a standard number of days, and most patients are successful. But some patients might not fall into the same treatment regimen. Maybe they need more medication or less medication or medication for a different time frame. We are right now just starting to assess studies of endometrial receptivity. Can we determine if transfers are done at the correct time, and can we make adjustments? Personally, my program is now undergoing a large study about this, and we're going to learn more. We're going to learn more about the endometrium itself. We've already identified over 100 surface proteins, some upregulated, some downregulated at the time of implantation. In the future, we will be able to make adjustments, and we'll also be able to identify proteins that are associated with abnormal situations. There's already studies looking at the BCL6 gene repressor biomarker and how it's associated with inflammation and how by certain treatments can improve endometrial receptivity. Now, I predict in the next decade, we will progress from not just testing genetic embryos for abnormalities, but to actually correct embryo defects. CRISPR is a gene editing technique, and worldwide news was made just recently about a birth in China of twin girls with the CRISPR edited genome. This is incredibly controversial. There are ethical issues. There are concerns about the, quote, designer babies. Will we be correcting embryos for height or intelligence or musical ability? I think this is unlikely. These are multi-genetic traits, and they're not going to be simply be able to corrected with this technology. But what if we could correct embryos for horribly deleterious genes, for Tay-Sachs, for Huntington's, for Alzheimer's disease? This would be a major accomplishment. This technology is not going away. We need more ethical guidelines, but I'm optimistic about it. And I predict that there will also be NIH funding for this research. I predict we're going to have breakthroughs to improve ovarian health, especially the low responder patient, the patient approaching transition. Right now, we deal with many supplements to try to help these patients. CoQ10, DHEA, royal jelly, melatonin, Chinese herbs, acupuncture. The studies about these supplements are unclear and show marginal benefits at best. But new treatments are on the horizon. There have been some animal studies looking at certain proteins. AMH, or luteinizing hormone, given to mice prevents chemotherapy-induced menopause. Is this a potential to help our low responder patients? We have much to learn here. I'm optimistic that we're going to find new ways to help our low responder patients. Patients in the transition we know have dormant follicles remaining in the ovary. There have been some studies showing that using bone marrow-derived stem cells and inserting them into the ovarian artery of patients might increase ovarian response and potential. There's evidence that if a sample of the ovarian cortex is removed, fragmented, and reimplanted, this might rejuvenate the ovary. We know the mitochondria in the cell is the battery, the powerhouse, the charger of the cell. Can doing mitochondrial transfer rejuvenate the aging oocytes? There's a lot of controversy here. And again, we hear about the three-parent baby passing along mitochondrial diseases. There's no doubt that we don't want a rapid expansion of this treatment before safety concerns are addressed. But this will be coming in the future. Now, we all know, or should know, that the biggest determination of a woman's fertility is age. And for that reason, we are going to see a lot more freezing of oocytes. It's going to be offered to all women. Patients often ask me, what is the best age to freeze oocytes? And there have been studies done, models created, but there's no doubt the correct answer is right now. Right now is the best time to freeze oocytes. And many large corporations understand this. Companies like Facebook and Apple are paying for this treatment. In certain companies, this is offered to our female military veterans and military combatants. We're going to see a lot more egg freezing in the next decade. I predict that IVF is going to be physically easier for patients to undergo. During the last decade, we've used much less progesterone injections, and many cycles don't use progesterone at all. There's already available an oral GnRH antagonist, the elagolix, which is used to treat endometriosis. There are studies looking at this drug to treat fibroids. It will eventually be used to help in IVF. There's experimental work with oral gonadotropin agents. I do believe that by the end of the decade, there will be the possibility of an IVF cycle with very few or absolutely no injections. The last thing I hope to see in the next decade is what Dr. Howard predicted, more availability of IVF to our patients. We now have about a quarter of states mandate that insurance companies pay for IVF, which still means that in 3/4 of states, there is no mandated coverage. And most insurance do not cover in vitro fertilization. And for our patients, especially who are underinsured or have no insurance or Medicaid, this is very difficult to undergo. And this especially affects our patients of color. In the next few years, there will be more lobbying efforts, more advocates. Infertility is a disability, and it's important that it be covered by insurance. And I believe this will happen in the next decade. Back in 1990, when Dr. Howard made his predictions, he was almost 80. And mostly what he predicted came reality in the next 2 decades. And Dr. Howard lived to see it. He died in the summer of 2015 at the age of 104 and a half, still vital, still advocating for the infertile patient. I do hope that when I look back in the next decade at what my predictions were, I hope that many will have come true. This will be wonderful for the field of infertility, and especially most wonderful for my patients.
Thank you so much for that.